presentation and welcome again Professor Lafroy with the topic of the role of the liquid for GI bleeding. Please.
So let's move on the second topic from my side about the role of liquids for GI bleedings in general. We use more and more liquids and liquid embolic agents for GI bleedings, whatever arterial bleedings, of course, but also venous bleeding, with different common theoretical advantages of cyanoacrylates and copolymers. We will see that in the next slides. The main advantages are that they are permanent. The risk of recognition is exceptional. This is highly penetrable. One of the main advantages to me is that the occlusive effect does not depend on coagulation parameters of patients, especially with glue, which is very, very interesting, especially in bleeding patients with coagulation disorders, which is not the case with other mechanical agents. This is highly hemostatic, very interesting for massive and focal bleeding with high radiopacity. You can reach distal targets with very small microcatheters, and sometimes this is the only option because in very small microcatheters you cannot put any coils or plugs, and this is quite easy to deliver. Of course, you know by heart the differences between glue and onyx, but in terms of copolymers, we have also EasyX, we have also Squid now from BALT, and Onyx from Medtronic, and glue, different glues, Histoacryl, Glubron 2 in Europe, and Magic Glue now from BALT. They have all the same behavior. So one is polymerization, the other one precipitation. Both can be controlled. I don't like to say that we don't control what we are doing with glue. This is not exactly the case. We have more inflammation probably with glue than with onyx. We can use both in a free or blocked flow manner. Of course, the philosophy of injection is quite different with glue, which is fast, as compared to onyx, which is slow. You can stick the catheter even with onyx if the injection is very slow, but let's say that the risk is higher with glue. Adhesive versus cohesive, and glue is really cheap as compared to copolymers, which are expensive. And glue has really gained acceptance if we look at the literature over the last 5 years, but the use for GI bleedings as compared to onyx. So the potential applications, as I said before, arterial bleeding, upper and lower GI bleedings, and venous bleeding also for varices. I will show you some examples of portal systemic shunts, ectopic or peristomal varices that we can embolize. So as I said, if we look at the literature, the use of cyanoacrylates has really gained acceptance of over the last 5 years. I show you on this slide the different papers published recently, and we have even more papers than that, especially in Asian countries, meaning that glue can be very interesting for both upper and lower GI bleedings with no more complications. I will show you why. So when to use liquids, very good indications and very good candidates in case of coagulation disorders, of course. In case of massive focal bleeding, as you can see here, with huge extravasation from the left gastric artery, we can sacrifice this branch without any issue. And this is very fast, especially at 3 o'clock in the morning, to put a microcatheter and two drops of glue, and it's done. There is no risk, given the important rate of collaterals in that area, and this is very easy to do, especially in case of hemodynamic instability, in case of small-sized distal and tortuous vessels, or for cavity filling. So let me show you some examples here of hematemesis and melena from bleeding duodenal ulcer at endoscopy. So of course at the upper tract we have usually endoscopy. We can see the metallic clip here from a branch of the GDA, and then we usually start with proximal coiling of the right gastroepipedic artery to protect it and prevent distal embolization with liquids, and then we use a 1-to-1 ratio glue Lipiodol in that case with a microcatheter to glue the rest of the GDA and the trunk and the main branches. And just this case to show you that we have to systematically check the potential backdoor bleeding from the SMA. In that case, you can see a small extravasation from a small branch, and it was impossible to put the micro more distally. So, of course, in that case, liquids are very interesting to reach the bleeding point from the tip of the microcatheter with, again, a 1-to-1 ratio in that case, and can really use very aggressive embolization in this area to avoid any bleeding because of collaterals. So here an old patient with bleeding diverticulum and massive hemorrhage, and you can see here this small extravasation here from a sigmoid branch of the inferior mesenteric artery, and you can see the microcatheter. It was impossible to get behind this point, and we use Onyx, as you can see here, in a blocked flow manner to get with low pressure liquids behind this point and to avoid recanalization. If you don't do this, of course, you have backdoor bleeding and potential recanalization. You can see how it is very radio opaque, and you can really see what you are doing as compared to microparticles, for example, and this is the final result. And you can see that we have recanalization from another branch of this area, but no recanalization of the bleeding, of course, meaning that you can really do a sandwich embolization even with liquids if you cannot go behind the bleeding point, which is very, very interesting. The same, you can do the same with glue. Let me show this example of a patient with left colon bleeding on CT scan. As you can see here with extravasation at the arterial and portal phase, and again a small branch of the inferior mesenteric artery. As you can see here, you can see the extravasation here, and a very difficult and challenging catheterism. You can see the extravasation. It was just impossible, even with a very small microcatheter, to go behind. It's not a big deal. You can really, from that point, use a glue with a 1-to-1 ratio and under low pressure inject and go behind the point to get distal embolization, to get sandwich embolization, and to get to avoid any recanalization. You can see the final control from the proximal port, and you can see that if you don't do sandwich embolization, you can get really recanalization from that branch. So if you embolize less than 3 vasa recta, the risk of ischemic complications is almost nil. And this is the case here. You do sandwich embolization from the tip of the microcatheter, even if, which is not possible with COIS. You have to put COIS at the tip of the micro, and if you cannot go behind the point, it can really be a shame and with a risk of ischemic complications, of recurrence of bleeding, sorry. Another example here of massive rectal bleeding. You can see CT scan, even if we have artifacts, you can see the bleeding from the rectal port, and huge bleeding with extravasation from branch of the left suprarectal artery. Very good indication in that case, instead of putting 3, 4, 5, 6 COIS, and because the patient is bleeding on the table, 2 drops of glue and it's done. And this is the final result with still patency of both suprarectal arteries. This is only a small branch with no risk of ischemic complications, and very interesting liquids for this kind of typical patient, I would say. But also for transtips varices, let me show you here transtips with recurrence of bleeding. This is like an EVM, and you need to reach the nidus. Otherwise, if you embolize too proximally with COIS or plugs, you will get recurrence for sure. And liquids, both cyanoacrylates or copolymers, are very interesting for this kind of embolization. It has been shown in the literature in some retrospective studies that cyanoacrylates are better than COIS for this kind of patients. But also for peristomal varices, let me show here an example. You see peristomal varices, bleedings by transportal approach, venous approach, and you can see the behavior. This is like a nidus of an EVM, and nothing is better than liquids for this kind of distal embolization. And you can see here with a 1-to-1 ratio, you have to make to make sure that to pay attention to any reflux, of course, and the proximal, the final result, and the proximal part was occluded with one more plug to avoid reflux, but it's very interesting to make sure that you don't get any recurrence. So any drawbacks of using liquids for that? Learning curve for sure, optimal dilution. You have to dilute with lipidolysis if you use glue from 1-to-1 to 1-to-4 ratio, according to the type of vessel you embolize. Injection, of course, but the risk of complications, sticking the catheter probably a little bit more with glue than with copolymers, but honestly, I've never sticked any catheter and left any catheter in any patient, so forget about that. The main risk to me is non-target occlusion, but at least you see what you are doing as compared to particles. You don't see the particles, you see the glue and you see the copolymers. So this is better in terms of fragile opacity. And the ischemic risk, of course, you have to pay attention, but most of people are thinking that the risk of ischemic complications is higher with cyanoacrylates and liquids, which is completely wrong. Of course, if you get reflux of liquid, it can cause non-target artery embolization, of course, or if you use too diluted glue in a high flow vessel, you can cause extensive embolization, but you have to be cautious. We know from the literature that to avoid the risk of ischemic complications, especially for lower GI bleedings, because for upper GI bleedings, there is almost no risk of ischemic complications, you have to embolize less than 3 vasa recta. With less than 3 vasa recta, there is almost no risk of ischemic complications. This is what you have to target and to get. If we look at the literature, this very nice meta-analysis, and we published recently in 2020 the same meta-analysis with more papers from our center with the same kind of results in GVIR with outcomes of upper GI bleeding glue embolization. As you can see, 82% in terms of outcomes with a 5.4% of complications. Overall complications for lower GI bleedings, quite the same, as you can see here. And they showed that among 440 patients, they got only 13 ischemic complications, meaning 2.9%, with only 3 needed bowel resection. Whatever the territory, upper or lower GI bleedings, meaning that this is even less than what is reported in the guidelines from the CIRSE, with all types of embolic agents, meaning that at least there is no more risk of ischemic complications, 3 needed bowel resection among more than 400 patients. I mean, you cannot do less. This is very safe, as you can see. And we published in European Radiology last year the largest comparative study comparing glue versus other embolic agents, and we showed that the primary 30-day clinical success was higher, significantly higher in the glue group, with less rebleeding significantly and shorter procedure, of course, because this is faster to do this, as you can see here. And glue was an independent prognostic factor in univariate and multivariate analysis, meaning that this is very interesting for upper GI bleedings. If we look at lower GI bleedings, the same, we can find some papers in the literature here showing that the use of glue is better, at least in univariate analysis, in terms of prognostic factors for clinical outcomes. And the same here with more than 130 patients, the use of glue leads to less complications and less recurrent bleeding significantly. So we don't have to be afraid of using glue for this kind of purpose, because you can get very distal embolization, but at the same time, it will not go through the capillaries. So meaning that this is at less risk of ischemic complications than small microparticles, because the mixture of glue and lipidol, and the same with copolymers, is very viscous. And if we look at the literature about the outcomes of onyx embolization, of course, less studies, few studies, 4 or 5 studies. The last one here is from our center with almost no major complications. We got 7 major complications, but unrelated to embolization, and no ischemic complications reported in this different series, meaning that maybe the risk of ischemic complications, which is already very, very low with cyanuracreates, is maybe even lower with copolymers, which is really a very interesting things, especially if we look at the literature about the CIRSE guidelines published in 2013, saying that in case of massive bleeding, glue and copolymers may be considered, but with increased risk of ischemia, which is completely wrong. If we look at the fresh and the recent literature, there is no more risk and probably even less risk with liquids in general than with other embolic agents. And overall, as you can see, the risk of severe ischemic complications requiring surgery is reported to be between 4 and 5%. And as I showed you in the meta-analysis, it was reported to less than 1% with the use of glue for both upper and lower GI bleedings. So meaning that this is really not the case, and this is very interesting to use liquids. So in conclusion, I would say that the use of liquid embolic agents, both cyanuracreates and copolymers, can be very interesting and feasible and effective for lower and upper GI bleedings, for arterial bleedings, but also, as I showed you, for venous bleedings. This is specifically interesting for massive and focal bleeding with extravasation. Very interesting for patients with coagulation disorders, because you don't mind about the coagulation disorders, which is very interesting in bleeding patients, and which is not the case with mechanical embolic agents like coils and plugs and whatever. You can really reach almost any bleeding site, even tortuous, small, and distal. It can be cheaper and faster with less radiation for you and for the patients, especially with the use of glue. As I said before, there is no more risk of ischemic complications from the literature. Of course, a learning curve is necessary, but as with any other embolic agents, and we still need evidence, but we have more evidence with glue than with copolymers, but some papers are on the way about the use of copolymers, different copolymers for bleeding patients with high technical and clinical success rates. So liquids are very interesting for this purpose. Thank you very much.